All right. Hello and welcome to this installment of the UCLA Esophageal Insights Zoom series of lectures. We're going to talk about the diagnosis and management of achalasia, perspectives from a surgeon and a gastroenterologist. I'm Alireza Sedarat, a gastroenterologist at UCLA, and with me is my distinguished colleague, Dr. Yanagawa from thoracic surgery. So we're going to define achalasia, figure out how it's diagnosed, and focus on the major endoscopic and surgical approaches to management. So a little bit of background. Achalasia is a relatively rare disease, although it seems to be increasingly diagnosed and recognized. The incidence is about 1 to 2 in 100,000. The cause is unknown, but it's thought to result from inflammation and degeneration of the myotomic plexus of the esophageal wall, which is located between the circular and longitudinal muscle layers. And it's thought that this is possibly an immune response to a virus exposure in genetically susceptible individuals. Herpes virus has been implicated as one of the potential viruses. Secondary causes include Chagas disease, paraneoplastic syndrome, or humoral mediated from, for example, lung cancer. Direct extension of a tumor, either metastatic or primary, into the GE junction can mimic achalasia. It occurs in all ages, males and females. It's important to understand that there's no cure per se. Treatment is palliative, but a patient that has achalasia will deal with that syndrome for the rest of their lives. So how do we define achalasia? Achalasia is Greek for failure to relax. It's characterized by incomplete lower esophageal sphincter relaxation and absence of normal peristalsis of the esophageal body. And how that esophageal body is abnormal is how we subtype achalasia. It's important to understand that that definition is almost a diagnosis of exclusion, because that same pattern can exist both manometrically and fluoroscopically in when there's an obstructing tumor or stricture. So it's with the exclusion of some kind of obstructing pathology. So do you have achalasia? What are the symptoms we're looking for? Dysphagia is obviously the most important one. It's often progressive over time, can be liquids and solids. There's often regurgitation of various consistencies, weight loss with sometimes severe malnutrition. There can be retrosternal pain and fullness. In some patients, aspiration and positional choking can dominate some of their symptoms. A atypical heartburn syndrome is possible, though it's usually not representative of true gastroesophageal acid reflux from the stomach, and generally antacids are not effective. It's generally related to an acidic environment formed by fermentation of retained food contents in the esophagus, causing burning. In general, none of these symptoms are particularly specific, and specific testing, as we're going to go into, is necessary to diagnose and, very importantly, to subtype achalasia. So what are those subtypes? You're probably by now familiar with this classification that is not too old. It came along around when I was a fellow, which is some time ago, I suppose. There's type 1, or classic achalasia, in which there's aperistalsis of the esophageal body. Type 2, in which there's something called panesophageal pressurization, which we'll go into that a little bit. And type 3, which has spastic contractions of the esophageal body. All of these have impaired lower esophageal sphincter relaxation in common. So how do you figure out if someone has a diagnosis of achalasia? Generally, an upper endoscopy is necessary to exclude a tumor, and plus or minus endoscopic ultrasound. Endoscopic ultrasound is a useful procedure in the evaluation of many patients with achalasia to exclude pseudoachalasia, to evaluate for typical findings of the muscularis propria layer, particularly in patients with atypical symptoms or manometry, or maybe a complex story where everything doesn't perfectly fit. Sometimes we use EUS as a tiebreaker to decide if a patient is likely to benefit from myotomy or not. An esophagram is important as a complementary test to endoscopy to assess for esophageal emptying and typical patterns that we would see. Sometimes it's useful if manometry and endoscopy don't agree as a tiebreaker. Sometimes esophagram may be useful. Manometry is super important, and pretty much all manometry at this point in 2020 should be high resolution esophageal manometry to allow subtyping of achalasia, but also to tease apart some abnormal manometry patterns or motility patterns that may be mistaken for achalasia without high resolution capabilities. A CT scan is sometimes useful if there's a high suspicion for malignancy, particularly in someone who's older, a smoker, personal history or family history of cancer, rapidly progressive symptoms and weight loss. These are sort of red flags, perhaps, to pursue cross-sectional testing early. pH testing may be pursued, particularly if it's unclear if the motility pattern is a primary motility pattern or if there's underlying reflux that's giving sort of a little bit of a weird motility pattern. So this is just a normal, for the most part, endoscopy. This was someone who was sent for dysphagia and had a esophagram that was suggestive, though not diagnostic. And you saw there that the lower esophageal sphincter opened very easily. And here's an esophagram of a normal patient, normal caliber, prompt emptying of contrast, and a relatively straight tube down to the stomach. And here's the normal corresponding manometry. This is high resolution manometry. From the top to the bottom is the length of the catheter. So this is distance along the y-axis. Along the x-axis is time. This high pressure zone at the top is the upper esophageal sphincter, and a voluntary swallow is initiated here with a drop in the pressure. And then this peristaltic wave with initially skeletal muscle and then smooth muscle propagating down the esophagus into the stomach with a coordinated relaxation, a drop of this pressure to basically equilibrate to stomach pressure. In these manometry studies, pressure and color are correlated, so higher pressure is a more scary looking color, reds, lower pressure is in these blues, and you can see the green pressure here of the LES tonically contracted with a voluntary swallow, it relaxes. So that's a normal high resolution esophageal manometry. Here's an abnormal esophagram, a dilated esophagus coming down to a point. This is a bird's beak with a little string of contrast emptying into the stomach and kind of a patulous distal esophagus with retention of contrast. This is somewhat typical and classic of achalasia. And corresponding to that pattern is this type 2 pattern, which is probably the most common or most typical one and easily identifiable. Here again, color is pressure. You see tonically contracted upper esophageal sphincter. A swallow initiates relaxation. But at the same time, the LES maintains its pressure. It doesn't relax. There's no real peristaltic wave of pressure kind of going down. And there's this elevation of pressure within the esophageal body. That's pressurization. It's a single column of isobaric pressure related to contraction that's non-peristaltic of the esophageal body against the closed door of the LES. And you can see at the same time that the lower esophageal sphincter rises a little bit in the body, so the esophagus is shortening. That's reflective of longitudinal muscle activity. So this is a very typical type 2 achalasia pattern. Very recognizable, and one of the chief advantages of high resolution manometry is that you don't necessarily have to be super facile with it. You can learn these pattern recognitions very quickly. Here's another abnormal esophagram. This is much more abnormal. It's a big dilated esophagus starting to approach sigmoid. You can see it's very tortuous, again coming down to a bird's beak with a narrowed lower esophagus slowly emptying. There's some filling defects and probably retained food in the esophagus. This is starting to be more advanced stage achalasia, close to what we would call sigmoid achalasia, and that's more likely to correspond to a type 1 pattern, wherein again, a swallow is initiated, there's no associated LES relaxation, so it satisfies that first criteria, and there's aperistalsis, there's nothing happening, it's a dead floppy esophagus, there's no attempt at movement, and so this is type 1. This is what the kind of textbook classic achalasia is, an aperistaltic esophagus with impaired LES relaxation. And so in both of these images, what would you feel? And this is a very crucial slide, and I want you to pay close attention, because when you do the endoscopy and you try to go through what looks like a narrowed, frothy, saliva-filled esophagus, you'll have a very typical sensation. It just kind of pops a little bit. And it's very, once you do it a couple times, and you've seen it a couple times, it's very suggestive of achalasia. Here's another type of achalasia that's distinctly different. The caliber is not dilated. There's still a bit of a bird's beak at the bottom, but instead of a patulous or wide tortuous esophagus, there are these indentations within the contrast column, and that represents spasm of the esophageal body. Each of these little divots or thumbprints are little areas of smooth muscle contraction. In its extreme, sometimes this looks like a corkscrew esophagus, and this corresponds to a type 3 pattern, or so-called spastic achalasia. Again, we have a voluntary swallow initiated, a hypertensive LES that fails to relax, but instead of having pressurization or instead of having aperistalsis, we have spasm, where color is pressure, very high pressures that are non-peristaltic. This is type 3 achalasia. And you can see that that spasm extends essentially the entire smooth muscle segment of the esophagus, a good 10 centimeters at least above the lower esophageal sphincter complex. I'll mention opiates here because they are a monkey wrench in the evaluation of these manometry patterns. And anytime that we're dealing with benign GI disorders, I think opiates are a punctuation point of caution for a variety of reasons. Relevant to our purposes, opiates can cause significant esophageal dysmotilities of varying patterns, including spasm, hypertensive peristalsis, EGJ outflow obstruction, achalasia-like patterns. They are many, and they're sometimes very difficult to tease apart from true achalasia or primary achalasia. Patients that have chronic opioids may have dysphagia and these dysmotility patterns. They often have pain-predominant symptoms, reminiscent of kind of narcotic bowel syndrome, except they have functional chest pain symptoms. They may be at higher risk of post-myotomy reflux due to delayed gastric emptying. And so whenever opiates are present and someone is being evaluated for possible achalasia, it's definitely a point of pause and worth a discussion about how best to manage. Usually the answer is try to get them off of opiates. So we'll talk a little bit about therapy. Now that we've diagnosed someone with some type of achalasia, we got to do something about it. If it was 400 years ago, we'd go to the beach and find a whalebone, and that's what Sir Thomas Willis apparently did. Cardiospasm was treated with dilation using a whalebone that I imagine would be similar to a Maloney dilator. Not sure why it had to be a whalebone, but there you go. About 100 years ago was the first description of a LES myotomy by Ernest Heller. This was an anterior and posterior open surgery that evolved into today's modified Heller, which is just an anterior myotomy and done laparoscopically. Failure of LES relaxation was termed achalasia first nearly 100 years ago. Fundoplications were introduced in the 60s. Pneumatic dilation the year I was born. Laparoscopic surgery in 1991. And Botox in the mid-90s, which was really interesting, but led probably to a massive overuse of Botox to treat achalasia. And then in 2010, the major change in this somewhat orphan of a disease was the Inoue myotomy, or POEM, as it has come to be known. So the options to treat achalasia, there's medications, anywhere from dietary changes to pharmacologic therapy, G-tube, Botox injection, pneumatic dilation, surgical myotomy, endoscopic myotomy, and esophagectomy. I'll touch on a couple of these, but for the most part, the rest of this is going to talk about POEM, and Dr. Yanagawa is going to tell us about surgical approaches. So just briefly, we'll talk about medications. There's not a specific medication for achalasia. All the medications that are used for achalasia have the interesting side effect of smooth muscle relaxation, notably in the esophagus. So calcium channel blockers, nitrates, sildenafil type medications may provide relief. Generally, the efficacy is low and partial. Side effects, desirable or otherwise, are common and limited to use, and generally not used as first line. I usually don't prescribe them unless a patient asks me to try like a nitrate or something like that. I do, however, particularly for jackhammer patients or type 3 achalasia patients, ask patients while they're waiting for their workup or their myotomy to give peppermint oil a shot, the main side effect being fresh breath, I suppose, but it can provide some degree of relief of chest pain, allow a little bit of prandial relief of symptoms, and that can be meaningful as a temporary measure. Botox, I think if you're going to take something about Botox out of this talk, is that think 2 or 3 or 4 times before you use it. Maybe consult with someone who has other stuff to offer, or before you do it. It's definitely overused. It's effective, and that's great, and it's generally safe and well tolerated, and that's great. But it's notably very, very temporary, providing weeks to months of relief. And that's both a plus and a minus in some regards. But once it wears off, people are tempted then to inject again. And repeated injections lose efficacy and duration of effect. And importantly, they can make the job difficult for the next guy because it introduces a fairly robust fibroinflammatory response in the submucosa and the wall of the esophagus that can increase the complexity and risk of complications of both the surgical and endoscopic myotomy. I think the main use of Botox, and it should be used selectively and appropriately, is in someone who is too sick for anything else. Their just life expectancy is on the order of months, and you want to provide some palliation. That's a really good person to Botox. They can't tolerate prolonged sedation. Doesn't make sense to subject them to a myotomy. Someone who has perhaps had a number of patients over these last few years that have comorbid decompensated cirrhosis with esophageal varices, that you don't really have many good options in that situation of portal hypertension, and those patients may get Botox. More commonly, though, I use it as a therapeutic trial in equivocal patients, meaning that someone whose symptoms, manometry, esophagram, and EGD plus or minus EUS don't all perfectly line up with achalasia. And I can't tell if a myotomy is the right answer. Botox is a good tiebreaker. If they respond to Botox, they'll likely respond to a myotomy. In one session of Botox will introduce some scar tissue, but it's usually overcome relatively easily with careful dissection. But I wouldn't do it more than once or perhaps twice if someone was twisting my arm. But that to me is its main use. Someone who you're unsure about and you want to get a little bit more information. Next step up in invasiveness is pneumatic dilation. These are larger caliber, non-compliant, stiff balloons designed specifically for disruption of the lower esophageal sphincter. And they generally range from 30 to 40 millimeters. The efficacy is fairly good, above 80%. Durability may be variable. Although in the randomized controlled trial of balloons versus a Heller myotomy from 2011, at the 2-year mark, it was as durable as surgery. Definitely some patients recur. It carries about a 4% esophageal perforation rate, which scares off a lot of people. And I think just as a practice, this seems to be more of a regional thing, whether people reach for a balloon or send for a myotomy. When POEM came around, I think pneumatic dilation really fell off a little bit more, and it's just not many people are actually trained to do it. If you do it right, it's very safe, and in some people, it's maybe appropriate. If they've had already POEM and Heller and they've recurred after years, that may be your only option left to consider. Generally, most people achieve relief at 35 millimeters. 40 millimeters probably carries a higher perforation rate, and so people get in trouble when they go too big too fast. It should be a gradated effort separated by a few weeks based on symptom response. So you've done all those things, and or at least considered those things, but you've decided now to send to surgery. And so I'm going to ask Dr. Yanagawa for a surgery consult.
Thank you. Well, moving on to the main surgical approaches for the treatment of achalasia, the main treatment is a Heller myotomy, which we've already started to talk about. I wanted to start by just talking about some of the technical details of this procedure. You can see here, your goal for the myotomy is to extend the myotomy at least 6 centimeters up the esophagus and 2 to 3 centimeters onto the body of the stomach. The first step is to really clear off the area where you want to perform your myotomy. And in addition to removing some of the fat that naturally exists in that area, you very critically have to identify and mobilize the anterior vagus nerve, which is pictured here. You can see how it goes from the left to the right and crossing right over where the myotomy has to go. When you create the myotomy, you go through the longitudinal layers and then through the circumferential circular layers, and then you should identify the mucosa, which usually looks a little bit more white and is smooth and shiny and sometimes even bulges out. As you cut through the muscular layers, there's sort of a characteristic crunch to it. In some cases, people will use the hook cautery, like you can see in this illustration here. But some people are very concerned about delayed cautery injuries leading to delayed esophageal perforations, and some people even prefer to use tearing as their primary technique in creating the myotomy. Other things to know about the technique, it's very helpful to have a bougie or an EGD inserted into the operative site in the esophagus, because that can help to spread the muscle fibers a little bit to help create the myotomy. And that can also help you create a straighter line. You do have to pay attention to how you're retracting the G junction to make sure that you're creating a straight line there. At the end of the case, we generally check for any tiny perforations that may not be obvious by insufflating with the EGD. If there are any esophageal perforations of the mucosa, that can be primarily repaired with suture. The minimally invasive versus open approach to Heller myotomy is not very controversial. It's pretty much accepted that the minimally invasive approach gives you a shorter hospital stay, less pain, with very similar outcomes. More recently, what has become more controversial is whether or not of the minimally invasive approaches, if there is any difference between laparoscopic versus robotic approach. There are some small studies out that may suggest that although outcomes are similar between the two minimally invasive approaches, the robotic approach may be associated with fewer esophageal mucosal perforations. I would imagine that that's related to the fact that with the robotic approach, when you use your instruments, you have wrist motion there, which allows you to perhaps be more precise in your dissection. And also the robotic camera gives you a component of magnification that may make it a little bit easier to see exactly where all the muscle fibers are. What are the results of the Heller myotomy? great symptom relief that's generally reported to be greater than 90%, with the low complication rate that's generally reported to be less than 10%. Here are examples of some of the complications. I just wanted to point out gastroesophageal reflux is generally reported to be less than 10%, but that is in the situation where myotomies are performed with a partial fundoplication, which we'll talk about a little bit more. In the setting of myotomy alone, gastroesophageal reflux as a complication is usually as high as 30 and 40%. I also want to point out the recurrent dysphagia, even though the rates are 10% or lower, usually are related to either progression of disease or an incomplete myotomy. The myotomy site can also scar down and lead to delayed recurrent dysphagia. You can also have a suboptimally performed fundoplication cause dysphagia, or if a patient has very severe reflux after the myotomy, they can also develop complications of the reflux disease that then leads to dysphagia. There was a randomized trial that compared myotomy alone versus myotomy with a partial fundoplication, and they found a very significant decrease in the development of significant reflux after with the addition of the partial fundoplication. Specifically in that study, they looked at the addition of a door fundoplication. That is not the only partial fundoplication that we use. The door is an anterior approach, like you can see on the left side of the screen here. The way this is performed, we mobilize the fundus of the stomach, and we bring up one edge of it and secure it with 3 stitches to not just the myotomized side on the left side, but also the crus on that side. Then we perform the same, fold over the stomach and perform the same 3 sutures on this side to both the myotomized sides muscle and the right crus, and then we put usually 1 additional stitch at the apex to put together the top of the fundus with the diaphragm, and that completely covers the myotomy site. This is considered an anterior 180-degree fundoplication. On the right side here, you can see the toupee partial fundoplication. In this case, this is a posterior fundoplication in which the fundus is passed behind the esophagus, and it is considered a 270-degree fundoplication. The 3 sutures are then attaching the fundus to the side of the myotomy on this side and that side. The pros and cons of the 2 approaches are that, with the door fundoplication, especially if you have an esophageal perforation, it's really nice that you have an entire coverage of that site after your repair. The other pro of this anterior approach is that it then doesn't require any additional dissection of the GE junction posteriorly, so you minimize any injury to the posterior vagus nerve. The pros of the toupee approach is that with the posterior fundoplication, you have tension on the 2 sides of the myotomy, and it's believed that that could help keep the myotomy open. There was a randomized controlled trial that tried to determine whether or not there was additional bonus for a toupee versus a door after a myotomy, and they didn't find any statistically significant difference, but there was a trend towards improved reflux control with a toupee posterior fundoplication. Although, surgeons are still very commonly using either approach for fundoplication, essentially nobody uses a total wrap, essentially a Nissen fundoplication, because that essentially will lead to dysphagia in a patient who still, even after the myotomy, essentially has a motility disorder, considering they have still esophageal aperistalsis. Comparing laparoscopic and thoracoscopic approaches, there are major benefits of the laparoscopic approach compared to the thoracoscopic approach. There are studies that show with the thoracoscopic approach, the results are not as good, that there is more incidence of dysphagia after the surgery compared to laparoscopic. And most likely that is related to the fact that it's a little bit more difficult to get onto the stomach from the thoracoscopic approach. The other main downside, if you have an option for both approaches, is that even with small incisions on the chest, those tend to be much more painful than small incisions on the abdominal wall. There are some scenarios, though, where the thoracoscopic approach might be a better option or a required option. One would be if there is a major contraindication to abdominal surgery due to previous abdominal surgeries. Also, the need for a long myotomy. This is an example on the right over here of a patient who had a variant of achalasia that extended over 20 centimeters. She had dysphagia that pretty much began right at the thoracic inlet. And so for her case, we actually started laparoscopically to do the Heller myotomy from the abdomen, and then used thoracoscopic approach to complete a long myotomy all the way up to the thoracic inlet. Thoracoscopic approaches might also be required if there's a very proximal esophageal diverticulum, although most epiphrenic diverticulums associated with achalasia can be treated from the abdomen. Esophageal diverticulum are associated with motility disorders. They can be treated with diverticulectomy at the time of myotomy. Not all diverticulum need to be resected. Small asymptomatic diverticulum actually a lot of times improve just with the myotomy alone, but very large or symptomatic diverticulum should be resected at the time of the myotomy. It's usually performed first. Here's an illustration pretty much of how it's done. It's a pretty simple technique, and we use laparoscopic or thoracoscopic endostaplers, and then perform a myotomy at least 90 degrees away from the diverticulectomy site. What is so critical for performing the myotomy at the time of your diverticulectomy is that you really understand the manometry findings prior to the surgery, because you really want to extend your myotomy for the entire extent of the abnormal manometry findings. Even though it's a relatively simple procedure, there is actually a significant complication rate associated with esophageal diverticulectomy, with several reports actually reporting up to 20% or more of a leak rate postoperatively. And so, for that reason, probably associated with the esophageal dysmotility, a lot of surgeons, even with the normal manometry, will extend the myotomy all the way down to the stomach. Having esophageal diverticulum used to be a contraindication to endoscopic approaches to myotomy, but actually, and used to be a reason why a patient would only be a candidate for a surgical approach, but that is no longer the case. And when we'll go back to our endoscopic approaches with Dr. Sedarat to talk about how endoscopic approaches are relevant for not just the typical cases, but even very advanced cases.
Great, thanks, Dr. Yanagawa. So that's a good segue into poem. And this talk came about a little bit because Dr. Yanagawa and I have shared our share of esophageal diverticulum patients that have become complicated. And I think we both learned a lot about the pathophysiology of that disorder. So POEM has been around now for about 10 years. It's an endoscopic myotomy that recreates Heller myotomy. It's the most widely adapted clinical notes procedure. And has kind of an interesting history. If you look back, actually, the very first endoscopic myotomy was in 1980. This kind of interesting publication where someone kind of MacGyvered a needle knife and basically directly, without a tunnel, just cut into the high pressure zone endoscopically in 6 dogs and 17 patients. I don't know how the dogs did, but apparently the patients did okay. And not surprisingly, this has not been recreated or reapproached for many years, but it's an interesting historical footnote. Um, in the early to mid 2000s, the idea of transoral or transluminal access to the peritoneum or the chest cavity with notes came into sort of fashion and discussion. And one of the approaches was to dissect a tunnel in the bowel wall to offset the mucosotomy point and the myotomy point and allow sort of a flap valve so that the closure would be more robust. Not really thinking about achalasia so much, but someone then said, well, we're here cutting muscle. Why don't we do a model for myotomy? And that was in 2007. And in 2010, Professor Inoue in Japan described his first series of 17 patients where instead of using a balloon dissection, he used ESD techniques to dissect the tunnel and perform a myotomy. And now fast forward 10 years later, and it's performed worldwide, thousands of patients by surgeons and gastroenterologists. And it was a really interesting history of a new technique that came about. As a side note to it, it was really the technique that made people pay attention to endoscopic submucosal dissection techniques outside of Asia. So really an interesting kind of history there. So now we have our interventional endoscopy consult talking about kind of POEM. And so who do we consider for POEM? And all types of achalasia can be considered, particularly type 3 achalasia is probably better served with POEM. Other spastic disorders of the esophagus, including jackhammer esophagus, where there's, like Dr. Yanagawa showed, a lot of spasm into the chest, where a laparoscopic approach wouldn't be alone adequate, and perhaps a less invasive approach than thoracic approach is desired. Previous Heller myotomy, failed or recurrent symptoms are probably best treated with POEM rather than surgery because the repeat dissection in that area would be difficult. Sigmoid esophagus, previously someone who had a very dilated tortuous esophagus sometimes wouldn't necessarily be considered for a myotomy, but those patients seem to do fairly well, more than one would expect, with POEM, perhaps because there's less dissection and scarring at the hiatus that may provide obstruction to a very aperistaltic esophagus. Extremes of age, I think the oldest patient that I've done was 94 or 95. The youngest that's been described, I believe, was 18 months or 2 years in Japan. I've done the youngest I've done was, I think, 17, and every decade in between. Epiphrenic diverticula, like Dr. Yanagawa was saying, is a really interesting sort of evolved approach about achalasia and esophageal dysmotility disorders. In general, I think we've learned that these areas of pseudodiverticulum form above an area of high pressure, and a weak point happens in the wall, and so mucosa and submucosa pouch out, and distal to it, there's some kind of motility problem. And it seems that for a lot of patients, an adequately approached myotomy is more important than just taking out the diverticulum. And so, like we were saying, the diverticulectomy can be considered if we have a very large or very symptomatic diverticulum, but it shouldn't be considered independent of a myotomy. And we've done now several patients who have had very large, very symptomatic esophageal diverticulum. Some of those are from failed previous both thoracoscopic and laparoscopic surgery, wherein an inadequate cardiomyotomy was performed. And so the area of the myotomy becomes a massive diverticulum. And those are challenging cases, but they are very dramatic responses. Someone who I just saw today, who was on basically 3 years of liquids, is eating normally now after a failed Heller with a massive esophageal diverticulum. So there's a lot of patients that we can apply POEM to, There are some patients that we can't. Portal hypertension is important. It's tough to safely dissect a tunnel when there's landmines of varices lying around. Similarly, bleeding that's uncorrectable or uncontrollable can be disastrous in a submucosal tunnel because the hematoma can cause pressure necrosis of the esophageal wall and someone can get very sick. Severe pulmonary disease is a relative contraindication. In general, what we're doing during a poem, and I'll show you some video, is we're dissecting. It's an intramural procedure, but there's CO2 gas being pumped into the mediastinum, into the chest, and with positive pressure ventilation that gets pushed below the diaphragm. As long as you're careful, the hemodynamic consequences of gas in those compartments are minimized. But if someone is starting out with severe pulmonary hypertension or bullous emphysema or otherwise is at rest, kind of teetering on the brink of hemodynamic collapse, pumping a little bit of air into their mediastinum is ill-advised. And so that has to be considered carefully. A poem relies on dissecting a potential space, a fascial plane, the submucosa, which in health delaminates easily and makes essentially another space, a third space, if you will. But if there's been significant disruption of that fascial plane with EMR or ablation or banding, or even severe esophagitis that's healed, radiation, things like this that would obliterate that layer, then poem doesn't become feasible because our working space is obliterated and the risk of mucosal injury and leaks is higher. And I'm going to throw in again opiate use as potentially a relative contraindication because those are uncertain patients. They have to be very carefully considered. So we evaluate someone for POEM, obviously an assessment of their symptomatology, endoscopy, esophagram, manometry, CT, preoperative risk assessment. It's definitely a minimally invasive endoscopic procedure or endoscopic surgery, whatever you want to call it. But it's still done always under general anesthesia and paralysis with a little bit of a PEEP. And there, especially in older patients, some variation or swings of blood pressure can happen during the procedure, and so it's not the type of endoscopic procedure that you can do on in someone who's an ASA 5 and otherwise wouldn't tolerate laparoscopy. So it's something to be considered that you have to be, although it's often applied to patients who are too sick to undergo laparoscopy, some of the same perioperative issues are at play. This is a commonly used dysphagia risk score that it's useful clinically. It's mostly useful in following patients for relative scores. It's the Eckhart score. It takes a conglomerate of dysphagia, pain, and regurgitation with weight loss into occasional, none, daily, or each meal symptoms. And in general, success in clinical trials is defined as a drop in Eckhart score below 2 to 3, depending on which study, which isn't necessarily perfect because you can still have an Eckhart score of 2 and have daily dysphagia. So that's a little bit perhaps flawed, but that's what's the most widely used. So immediately pre-poem, management of blood thinners is very important, obviously. Delayed bleeding is a feared complication because it's in an uncontrollable space potentially. It's not a regular GI bleed where you can go in and cauterize something. Accessing that area surgically would be difficult. There have been reports of early bleeds within the first few days of people going into the tunnel and performing hemostasis, but I'm only aware of maybe 1 or 2 case reports. The tunnel very quickly seals itself after a few days, so if there's a hematoma or a bleeding point, that may be challenging. So we want to be very careful and mindful of bleeding risk going into it. 72 hours of liquid diet to allow the esophagus to properly empty. Some patients have very severe stasis esophagitis despite relatively mild symptoms. They have almost a second stomach. And that becomes a problem because the integrity of the mucosa may be compromised. And so in a handful of patients, we've had to put them on complete esophageal rest with a G-tube because their esophageal mucosa was so deranged from stasis that a tunnel would not happen. It would just immediately break down, and they would have, a pretty bad leak. And so it's very important to allow the esophagus to empty and not be inflamed with stasis or candida. And in some patients, we prophylax with nystatin swallows for a few days prior to the procedure. This is a quick cartoon of what a poem is. It's a relatively simple and elegant procedure. The submucosa is expanded with injection, dissected with standard endoscope and electrosurgical knives down to the cardia, and then a myotomy in parallel to that down to the cardia. The hardest part of the procedure that makes the biggest difference is knowing that there's adequate extension of the myotomy into the cardia. So an adequate cardiomyotomy is crucial to success and sometimes much more difficult to determine than one would think. And then at the end, the only hole that you have there is the 1 or 1.5 centimeter incision into the esophageal wall proximal to your myotomy, and that's closed with a pretty robust seal. So here's a quick video. This is a pretty early case. You see a very spasm. There's your pop into the esophagus. This is an anterior myotomy, standard injection needle injecting into the mucosa, a blue-dyed saline solution, and a knife with endocut settings making a mucosotomy down the esophagus to be the entry point for this intramural procedure. And making a space for yourself with dissection of the submucosa, that gauzy, wispy, delaminating layer, that's the submucosa that looks kind of like fascia if there's any surgeons with us. That's the space that we're looking to expand. And now we're into our tunnel. We're looking at the blue-dyed submucosa, and we're expanding it. In this case, we're just using our standard water jet, just hooked up to a blue bottle, water with some blue dye in it. And we're expanding and lengthening the tunnel by dissecting the submucosa just above the muscle layer. And so you can see the white circular muscularis propria layer being preserved, and we're just riding just above it to preserve the mucosa. And even buzzing a little bit on the muscle is a good thing there, because we really want to be away from the mucosa. And this kind of opposite procedure, a perforation is not a hole in the muscle, a perforation is a hole in the mucosa. And so we're being very careful to be close to the muscle layer and having a nice generous cushion of fluid to protect us from mucosa. Isolate a vessel there, a cool little device, which is a hemostatic forceps. The very first poem I was privileged to see was by Dr. Inoue at a course I was attending with my father, and I remember seeing this device used, and it just blew my mind. I don't know why, for some reason, the coagulation forceps was the coolest thing ever. So now the tunnel is complete. You can see now you lose all sense that this is within the wall of the esophagus. It's just a new lumen. And we've extended it well into the cardia for a couple centimeters, and now the myotomy is starting. And so the dissection then focuses on finding the plane of tissue between the circular muscle layer and the longitudinal layer, and you can see we found that there and are dividing now the circular muscle layer. In achalasia, the circular muscle layer becomes very thickened in the esophageal body. The LES itself is thin and fibrotic and atrophic, which you can see right there. But proximal to that, the circular muscle is thinned. The longitudinal muscle, which you see is just kind of gingerly splitting away, remains very, very thin. And outside of that is adventitia of the mediastinum, and at that level, just next to the pericardium there. And now we're dividing muscle into the cardia, and we've basically gone into the cardia far enough. Their myotomy is complete all the way down. And these tend to be roughly 2 to 3 centimeters of cardiomyotomy, 1 or 2 centimeters of the LES complex, and then variable length of esophageal body myotomy depending on the type of achalasia. Usually for type 1s and 2s, we're ending up with somewhere between a 7 to 10 centimeter myotomy. And for type 3s, 15 to 20 centimeter myotomy. And you get immediate sort of feedback that your lower esophageal sphincter is nice and relaxed. And the closure is of your mucosal incision with standard hemoclips. And because that mucosal entry site is offset from the myotomy site by a distance, that provides you some degree of like a flap valve that maintains the integrity of the of your esophageal lumen relative to the mediastinum. And the incidence of mediastinitis is actually, at least in published series, very, very low. And in our series, it's zero, thankfully. So that's a quick snippet of poem. So post-poem, generally we keep patients overnight for observation with nausea and pain control. Pain is relatively low in general compared to laparoscopic surgery. We keep them MPO and have a post-op day 1 esophagram to assess for a leak. If no leak is seen, they're given a diet challenge and they're discharged on a puree diet for 2 weeks. And they're given a PPI, whether they feel reflux or not. And this is a super, super important point. Particularly within that first couple of weeks, any acid exposure to the freshly myotomized esophagus is dangerous. The only almost delayed leak I had was a patient who there was a language barrier and didn't understand that she had to continue her PPI. And roughly 10 days after her poem, she had fevers, and I didn't scope her at the time, but I suspect that she had pretty severe erosive esophagitis and just eroded into her mucosa, just enough to give her a fever. She had essentially a contained leak, and because it's an intramural procedure, it was not anything that needed more than antibiotics, but it was very educational. And so we keep patients on a PPI until they're well healed and well recovered. I usually see them a month or 2 after their poem to see their usually big smiles and and happy faces. And if they're on twice a day PPI at that point, if they're feeling okay, bring them down to once a day, keep them at once a day. And all of our patients, we try to get a Bravo pH study, 48 hours or 96 hours, depending on the situation, off of a PPI a few months after the poem. And I do that to identify patients that have significant asymptomatic pathologic acid reflux, because there's implications long-term about that. And you can't talk about treating achalasia without talking about reflux and its implications. There's reports of severe esophagitis that remains asymptomatic until very late. Peptic strictures and also Barrett's esophagus post-poem have also been reported. Generally, I don't repeat esophagram and manometry for all patients, although some centers do. I reserve that for patients who maybe don't have the best response. Most patients by far aren't getting routine manometry. We're going based on symptoms and endoscopic appearance of treated achalasia at that routine post-op Bravo. In general, outcomes are excellent, more than 90% efficacy with, increasing follow-up, now closer to 5 years and some studies 7 years follow-up. The efficacy in general for type 1 and type 2 is comparable to Heller. And it's probably established or accepted that it's superior to Heller for type 3 achalasia for the kind of just geographic, if you like, reason of not being able to access far enough into the chest across the diaphragm in a lot of patients for adequate esophageal body myotomy. So over the last year or two, we had a couple of randomized controlled trials that were very interesting and I think educational for us. One was in JAMA here, a international RCT of POEM versus pneumatic dilation with a 2-year follow-up. And efficacy by far in POEM was higher than pneumatic dilation, though there was a cost of increased GERD with esophagitis. And there was one perforation related to pneumatic dilation. So this was an important step that confirmed what a lot of the physicians that see a lot of achalasia patients suspected, which is perhaps that POEM is preferred over pneumatic dilation for primary therapy. And this was a much anticipated trial from, sorry, this is for some reason the reference isn't there, but this is a New England Journal from 2020. It was a multi-center European RCT that was designed as a non-inferiority trial of POEM versus a Heller with a door with 2-year follow-up. And the efficacy was equal, basically confirmed non-inferiority, and also confirmed what a lot of us probably suspected, which is that reflux was a little bit more common in POEM, which is essentially a myotomy without the fundoplication at 2 years. Interestingly, when you look at that reflux data, you learn a couple of things. The first is that a door fundoplication does not guarantee that a patient doesn't get reflux. And previous, telling data was things like 5%, 10% risk of reflux. A lot of that was based on symptoms. And so depending on how you measure reflux, whether you use pH metry, esophagitis symptoms, you're going to get different risk percentages for reflux. So, esophagitis is probably a good one. Anything more than B esophagitis should be considered clinically significant. We're a little bit more conservative at our center using not just esophagitis, but objective pH data to define reflux, because I think that has long-term implications that we're just not aware of yet. Interestingly, in this study, the initial, I'm not showing that data here, but the initial reflux rates were slightly higher in POEM at the 3-month mark and slightly lower in Heller at the 3-month mark. So it seems like with time, there's a trend perhaps for the risk of post-myotomy reflux approaching each other. So I think this just highlights that reflux has to be considered and monitored and aggressively treated in someone who has their achalasia treated. It's very easy and common for someone who has achalasia treated. They feel back to normal. They're usually healthy people kind of going into it. They just kind of disappear until they have a problem. Unfortunately, then we see those problems, and I've seen both POEM patients and Heller myotomy patients that have recurrent dysphagia, and you scope them and they have severe reflux esophagitis that require high-dose PPI and serial dilation. And you get them there and they get relief, but it's something that could be avoided. And obviously in increased awareness of esophageal cancer and Barrett's esophagus, that also has an implication. So something to consider. Serious adverse events that were reported, these were non-significant, but it was not powered for it, though there was a trend for higher serious adverse events in Heller, and that included 3 mucosal perforations, 2 of which required repeat laparoscopy and primary repair. Just briefly, we'll talk about a little bit more what we touched upon, that POEM is increasingly applied to non-achalasia spastic esophageal disorders, including jackhammer esophagus. The efficacy may be slightly less compared to achalasia, primarily for pain symptoms. It's a little tough to know how patients will respond to pain. Certainly, it's better than the pre-POEM era in general. But I tell patients routinely that I'm fairly sure I can make your dysphagia better, but if your pain gets better, I'll take credit for it, but I'm not sure if it was me or not. So it's a little bit of a tough one to predict. That being said, still the majority of patients, their pain does get better. I've had a number of patients who had persistent pain. In fact, someone that I just saw today, severe persistent pain after a POEM, despite adequate acid reflux control, and have responded remarkably well to tricyclic antidepressants. And so I think that highlights that their achalasia is a neuropathic disorder before it becomes a myopathic disorder, and some of the painful disorders or manifestations may be reflective of that in some patients. The phenotype may be potentially more variable than we understand. And then EGJ outflow obstruction is a special situation. Some of these patients act very much like achalasia. They look like achalasia on endoscopy. They look like achalasia on esophagram. Their muscle in their esophageal body looks like achalasia. Those are probably obvious and appropriate for POEM or Heller. There are some that have EG outflow obstruction that they may have dysphagia, but it doesn't have the flavor of achalasia when you scope them. It looks like wide open. They may even have a little bit of reflux esophagitis, which makes you scratch your head. How can they be refluxing if they should be having LES spasm? And those two things can happen together. We know that some patients can have TLESRs and things like this, but not enough perhaps to have persistent acid exposure and reflux. And so those are some patients, for example, that may benefit from a therapeutic Botox trial. And if they respond, then moving to myotomy. And if they don't respond, what I would often say is they tend to have relatively mild symptoms compared to true achalasia. Often we'll have them come back in a year and repeat manometry and see how they may have evolved. So definitely something that's a special case. I'll touch on this just very, very briefly. Reflux is, we've talked about a lot of this already. Reflux is super important after any method of treating achalasia, particularly any method of myotomy. And it really depends on how you define it. You're going to capture more patients if you use pH measures as opposed to just symptoms. What's very important, and I try to hammer home with both referring physicians and patients, is that symptoms are not a good measure in achalasia patients of acid reflux. Perhaps from just having, a neuropathic esophagus, or perhaps from having a dilated esophagus that's, adapted to having a lower pH ambiance from fermentation. About half of post-myotomy achalasia patients may have no heartburn symptoms and have significant pathologic acid exposure on pH measures. And so I'm just going to hammer it home again that we really need to pay attention to this entity. Adverse events post-POEM are relatively rare, generally comparable or favorable compared to laparoscopic surgery. And these are mostly case reports that have been out there. There's not a whole lot of massive experience about these because thankfully the incidence is relatively very low, but you should be friendly with someone like Dr. Yanagawa if you're going to be doing this, because at some point you're going to come to her hat in hand and say, "Doctor, please help." And usually she smiles and says, "Of course," and she's very nice. So we've done good for most patients, but we know that despite perfect LES treatment, roughly 10% of patients may still progress. And so then what do? We call Dr. Yanagawa again.
Well, this is a patient that GI did call us about. This is a patient who had a history of achalasia and had a balloon dilation 20 years earlier, but still had some dysphagia afterwards, but just figured out how to compensate and essentially had been on a liquid diet for 20 years. And so when he presented, he was, practically drooling from the obstruction from all the impacted old food in there, which couldn't be removed with an EGD. So we performed a rigid bronchoscopy and fished out just a ton of clay, essentially. And so these are some of the really extreme cases that we see with end-stage achalasia. Even patients who have, major anatomic changes like sigmoid esophagus from end-stage achalasia may still be reasonable candidates for myotomy, either endoscopically or laparoscopically. This is an example of a patient who was in his 20s, actually, who presented with this very severe sigmoid esophagus on his esophagram, but a year and a half after his laparoscopic myotomy had this marked improvement. Of course, not every patient responds that way, and for patients who have repeated failures to other interventions or have severe poor emptying from the anatomic changes of the body of the esophagus, or have complications related to their severe reflux, for example, really bad strictures, it may get to the point where the only consideration for relief of their symptoms is esophagectomy. How do we plan to do an esophagectomy for someone like this? It really, there are many options actually, and there are a lot of different things to consider. If you do a short versus long segment, for example, you can plan to remove the majority of the esophagus and have your anastomosis be in either the chest or the neck. The two options for performing that surgery, on the right here, you see, example of how we perform a transhiatal esophagectomy, where we have an abdominal approach to mobilize the stomach, and then a superior approach from a neck incision, where we dissect out the esophagus, and we ultimately pull the stomach up by bluntly dissecting the middle portion of the body of the esophagus between those two incisions. That is probably associated with more risk for achalasia patients than compared to a transhiatal esophagectomy for other diagnoses, just because they have so much chronic inflammation and neovascularization around their esophageal abnormality. The other option, transthoracic, whether or not you go into the right chest or the left chest really depends on where you're placing your anastomosis. If it's high in the chest, the right chest gives you the best exposure of the entire length of the esophagus. For a short segment, however, the left chest gives you great exposure to the GE junction. You have three options essentially for conduits when you're doing an esophagectomy, with pros and cons for each one. When you use the stomach, the pro of using the stomach is that it's only one anastomosis. The downside of using the stomach, though, is especially if you're only planning to take a short segment, if you make your anastomosis low in the chest, you can have very, very severe problems with reflux after that. If you use the colon or the jejunum as an interposition, it preserves the stomach in the abdomen, so you may have less dumping syndrome or delayed gastric emptying and less reflux. The jejunum is a shorter length, so really only suitable for a shorter interposition, and the colon, as you can see here, can be harvested to a length that reaches the neck even. You may wonder, a lot of these patients are not healthy and really malnourished by the time they get to this stage, but and it may seem that an esophagectomy might not be something that they would be considered a surgical candidate for because it's such a major surgery. But in this study from the National Inpatient Sample, they found that actually the in-hospital mortality of patients with end-stage achalasia undergoing esophagectomy actually had a lower rate of in-hospital mortality compared to esophageal cancer patients undergoing esophagectomy, and they had actually very similar complication rates. And in this study, they found, they did an analysis of the multiple small studies on patients and their quality of life after esophagectomy for the diagnosis of end-stage achalasia, and they found very high rates of symptom relief. So why don't we go over the poem take-home points?
Great, thanks. So, so poem is it's a great, elegant little procedure with with good efficacy for achalasia and other spastic disorders of the esophagus. Similar outcomes to Heller myotomy for type 1 and type 2 achalasia, and probably superior for type 3 achalasia and other long segments of esophageal spasm. And it seems to be emerging as the preferred treatment modality for achalasia, with the caveat that management and recognition of post-myotomy reflux is crucial to post-POEM patients. And I think it highlights the lessons that we learned from POEM, I think highlight that what we probably should have learned from Heller myotomy, which is that anyone who gets treated for achalasia should be monitored long-term, particularly for development of reflux and its consequences.
And our additional conclusions are, in summary, that achalasia is a lifelong chronic condition. Both endoscopic and surgical approaches require long-term follow-up and management. Both surgical and endoscopic approaches both require detailed attention to adequacy of the myotomy. Diverticulectomy, when being performed, must be based on the assessment of manometry information in order to provide an appropriate myotomy at the same time. Patients with end-stage disease can have good quality of life and improvement of symptoms with esophagectomy, and that management in general should require multidisciplinary approaches. Thank you so much, everyone, for joining us for this Esophageal Insights Zoom series on achalasia.
Thank you.